Hello, everyone. Welcome to a Global VMR. Today we have a special guest, the residents from Mayo Clinic from internal medicine. We are really happy to have them here. So if Jack and Vanessa, if you can introduce yourself.
Yeah, thanks, Deborah. Hello, everybody. It's really great to be here. Myself and Vanessa Golee, one of my co-chiefs, we're two of the four internal medicine chiefs at Mayo Clinic, which is an extra year here at Mayo after the 3-year residency. Myself, I grew up in Ireland, and I trained in University College Dublin. Did a few clerkships in the US when I was a medical student, and just finished 3 years of internal medicine residency at Mayo, and then I'm going to go into infectious diseases fellowship next year at Mayo as well.
And my name is Vanessa Golee. I'm from Washington State originally. I went to medical school in Loma Linda University in Southern California before coming out east of the Rockies for the first time for a residency here at Mayo. Just like Jack, currently a chief resident here at Mayo. We just had our match day for fellowship 3 days ago, and I am, very exciting. And I am also going into infectious diseases. It's very much the best specialty. I have a PowerPoint for any of you who are interested about why it's the best specialty. And I'm going to do an ID fellowship at Stanford.
That's great. Congratulations, you all. So I think we can start with the case. I think who will share their whiteboard? Aya?
Can you guys enable screen sharing?
Ooh, just a second.
Vanessa just made me some beautiful pour over coffee, so this is my energy levels are about to rise by at least 20%.
Ooh, fancy.
I know, right? It's so pretty. They worked so hard on this whiteboard. It took like 2 years to perfect it.
It looks great.
I have a sneaky suspicion that this case might involve a tiny bit of infectious disease, or
we were talking about it yesterday. I told him, don't give me any clues. Don't tell me anything. Idea, I won't be mad.
Vanessa, have you discussed a case before?
This case? No, I told him.
No, not this case. A case. Like, have you been blinded to a case before?
Oh yes, one time.
How was that?
It was good. It was a case of Whipple disease.
Whoa,
Which
okay.
unfortunately is an infection I don't know very much about. But we still got it.
We have an expert in the house in the form of Andrew Sanchez, who can tell you much more about Whipple's disease.
Yeah, I just presented that like 6 months ago to you, Robbie.
That's awesome.
I've got to plug our residents, but the case was published in the New England Journal this week. Yeah.
Oh shoot.
Yeah. It was in the like clinical problem solver kind of section.
Amazing.
Yeah.
That is so cool. I can't wait to solve it and pretend like I knew it from the very get-go.
Yeah. So you got to open it up in front of your colleagues now and go, oh my God, this is Whipple's. Like,
based on the title alone, it's got to be Whipple. I know it. Amazing. Well, I think the goal for today is to really hang out, talk some medicine, and then shed light on your wonderful program through your lens and through the case. And I really appreciate you making the time to be here, and excited to nerd out with you both.
Thanks, Robbie. Thank you for having us. We're really pleased to be here. So shall I just jump into the presenting? Yep.
Let's do it.
All right, let's go. So the chief complaint was, so it's a 71-year-old male, and he presented to our hospital with a 6-month history of abdominal discomfort and a 15-kilogram weight loss. And he had a 1-week history of diarrhea.
Really? Whipples? Is this it?
This is ringing a bell.
Oh my gosh. What are you thinking?
Okay, so I think the first thing I would start with is asking more about the abdominal discomfort, aggravating, alleviating factors, if it has progressed over that amount of time, is it constant, is it intermittent? And if they notice any particular pattern to the abdominal discomfort.
Go for it, Jack. Indulge us.
Okay. Yeah. Okay. I can give more information. Perfect. Yeah. So when I asked him that, he said it was really actually kind of like a feeling like the abdomen was swelling. It wasn't, there was no, specific, there had been one alleviating factor, which I will get to in the next aliquot. But no, this has been a kind of progressive swelling and kind of a tension associated pain in his abdomen.
Okay. So it was just kind of a bloating, swelling, not actual pain or anything like
Discomfort, yeah, more of a
Okay.
discomfort, yeah.
Okay. Was his belly actually becoming distended?
Yes, it was becoming a little distended.
Oh,
You
okay.
noticed, yeah.
Okay. Okay.
Yeah, Vanessa, I'm curious what there's a lot of data on the board. You can tell, like, and Aya, a brilliant medical student who's applying this year, actually is very kind enough to highlight things for us in red, which is very informative. And I'm curious if you had to say what grabbed your attention the most of these things, what stuck with you? What struck you?
So the things that stand out to me the most are that it's 6 months, that's subacute ranging to chronic, and that that worries me, that it's especially the fact that it's progressive. That tells me it's a pathology that is continuing to grow and isn't something that will just burn out and be over. The other thing that really worries me is the 15-kilogram weight loss. That's a lot of weight. I'm assuming that was unintentional.
Yeah, unintentional.
Yeah. So next thing I want to know more about are constitutional symptoms, because of course, constitutional symptoms like that really start worrying me a lot more for subacute infection, malignancy, severe rheumatologic disease, that kind of thing.
Yeah, I completely agree with you. I think that's exactly the train of thought my mind is going down. And I find myself asking a question which is much more practical, which is, what are the chances you think that his imaging, namely his CT, will not provide you with tremendous information? Because I think that the chances are that it's going to be very, very helpful. So is there anything that is giving you a sense of what the CT, which is, I think, the key test in this patient, what that might show?
Well, I think that especially if he's having actual abdominal distension, that would really worry me. Is there some kind of mass or some kind of growth in the abdomen? So that would make me suspicious, just as you said, that a CT abdomen pelvis would be much more of higher yield. The other question I always think too, we still have a few more history items to gather, but the other thing that I always think about is, okay, what is the best kind of imaging? A CT abdomen pelvis is the easiest thing to get when somebody comes into the emergency room or something like that, which I'm also assuming, is this an emergency room admit or is this a clinic?
No, yes, correct. It came through the emergency department. Yeah. And I was a floor second year resident.
Okay.
Yeah.
Okay. So then, the other thing that I'm thinking about too is CT abdomen pelvis logistically is the easiest imaging scan to do. But I also want to think about, is that the best one to do versus, something endoscopically? And I think that's where more history is going to be helpful, because, abdominal distension and discomfort, weight loss, and now change in bowel habits, that could also make me worry about, would a colonoscopy actually be more appropriate?
Yeah, 100%. I completely agree with you. And I think that if you analyze the abdominal distension in a very simplistic manner and ask what phase of matter is actually causing the belly to become big, is it an increase in amount of gas, or is it an increase in liquid, or is it an increase in solid stuff? I think that you could actually start to make some educated guesses, which is, I think what the CT might show is, it might tell you, hey, there's a lot of gas in the belly, there's a lot of fluid in the belly, or there's a lot of solid material. And I think that most of the time, when there is increased gas, it's either free air, which is much more acute and therefore unlikely, or it's contained air in the form of an obstruction or ileus. And the thing that you'll almost always find in people who are obstructed, who have an ileus, is they have a lot of nausea and anorexia. So the lack of that is making me think that that solid material is probably not at play here. And then it's a question of, is it liquid or is it solid? And I think that teasing between those two things is a little bit tough. And by solid, I mean a lot of lymphadenopathy or hepatosplenomegaly, or a large dominant mass like a sarcoma or a retroperitoneal conglomerate of lymph nodes. That can be isolated to the belly. If we are dealing with liquid distension tends to be accompanied by lower extremity edema, and we haven't done an exam yet, but he hasn't reported it. So I think for me, I'm really, really curious what phase of matter is involved in this disease process, because if it's organomegaly, I bet you're going to have to take that tissue out and study it. And if it's fluid and ascites, I bet you're going to have to take that out and study it. So the presence of abdominal distension here, essentially, for me, is enlightening us that the disease is declaring itself in a mass-like form, either as a solid or as a liquid, and analyzing what that mass-like form is going to be so important.
Yeah. So can I ask Jack, has he had any drenching night sweats where he has to change his pajamas or change his sheets?
He is not. No fevers, chills. Hasn't noticed any kind of, lumps in his neck or anything like that either. Yeah.
And this weight loss, has his appetite actually changed? Has his appetite gone down?
He has anorexia.
Okay.
Yeah.
And is it because he doesn't want to eat, or because when he eats, it makes the abdominal distension and discomfort worse?
It was the former. Yeah, he didn't want to eat.
Okay. Yeah. Nausea or vomiting when he eats?
So should I just give a little bit more of information?
Yeah,
should I drip another little bolus at you guys? Okay. So
drip it away.
Yeah. All right. So let me tell you a little bit more. So I'll just start with the 1 week of diarrhea that he'd had. So he was having up to 12 stools a day, and they were type 5 to 7 on the Bristol stool chart. Somebody asked, were they bloody? They were not bloody. He'd had so in the last week, he'd had a more diffuse abdominal pain along with this diarrhea, and really hadn't eaten much. Didn't have any dysuria or hematuria, and he didn't have any fevers or rigors, as we mentioned. He had one episode of non-bloody non-bilious emesis during this 1 week period. But to give you a bit more background on the past 6 months, so as I mentioned, the weight loss had been gradual. It was non-intentional. It was greater than 10% of his baseline pre-morbid weight. And he'd also noticed that his ankles maybe had become more swollen when I kind of dug into that a little bit more. The kind of piece here, and this is something we encounter frequently at Mayo. He had been worked up for this a little bit already, at an outside hospital, and but of course he didn't have his records, and he arrived on the floor at 2 a.m. in the morning. So all I had to go on was this story that he had told me.
That's actually one thing that I have been thinking about a lot, especially as I have ended residency, is how we talk so much in medical training about being judicious with our medical tests, medical imaging, all of that. And one of my consultants, which is what we call our attendings here at Mayo, I was talking with one of my consultants about it and saying, I struggle because sometimes, especially when I admit patients in the hospital, I find myself reaching for these expensive tests and expensive imaging. And I don't think that's what I was supposed to have, be always doing. And it was really helpful because even if I don't have these records, even knowing that this has been going on for a while, that he's been evaluated locally, and that there hasn't been an easy answer, this is much more of a practice, but that makes me more likely to say, okay, this is potentially something that's a little bit more complicated. The fact that he's also having lower extremity edema, that makes me think about a couple of different mechanisms for that. One potential is, this mass effect that's going on in his belly somehow, is that making it harder for venous return to happen from the lower extremities. The other thing that I wonder about is, especially if he's having some systemic process, is it just the ankles, or is it pretty spread through his legs that he's noticed?
What he described to me during the history was just the lower legs.
Okay.
Yeah.
Okay. The other thing that I think about too is if somebody's actually getting pretty ill, if they start getting hypoalbuminemia, that kind of thing as well. But especially there's a lot pointing towards mass effect in the belly. So that is what I'm more concerned about. in this case.
I am right there with you, right there with you. And sorry, I'm eating a very, very sour piece of salad. Oh my gosh. Wow. Whoever's seasoned this really needs to work on it. And by the way, that was me. What do you think? Solid, liquid, or gas? What do you think's in the belly? Because I'm ready to go all in, Vanessa. I'm ready. Once the liquid starts to pop up in the legs, I bet you that's what's the belly. And so you can start to be a step ahead.
Yeah.
I think what I would do in real life in this patient is put an ultrasound probe on them because of one fact. No matter how good we think we are, as in all comers, there's a very nice JAMA review that talks about, even in the best of physical exam hands, the ability to detect ascites is limited. I would put a probe on this patient and I would use that to gauge the probability of ascites, but I would give it upwards of 80% here based on the fact that there's abdominal distension, no nausea, no vomiting, so gas is unlikely, and then there's liquid in the legs. The liquid in the legs tells me there's ascites. So honestly, my mind is rushing ahead towards saying, hey, this is a person with subacute ascites. And I'm more than happy to be wrong, but I'm doing this thought experiment simply to ask myself, is there anything I can do to make progress if this turns out to be the case right now, and shape my evaluation based on an 80% chance that it is ascites, right?
Right.
So immediately I'm like thinking, okay, ascites, what would I do next? So if we pretend that we know this is ascites, what thoughts would then cross your mind as possibilities? If we had that as a working hypothesis, what would that do to your analysis?
The next thing I start thinking about is the mechanism of ascites, especially, do we know anything about this man's past medical history?
Should I fill out the bottom left corner of our
let's do it.
here? Let's do it. Okay. So here's the kind of a little important piece of information. So what he told me was that he had been diagnosed with cirrhosis and ascites in an outside hospital, and he had one paracentesis around 5 weeks before presentation. He wasn't really able to give me more details in terms of how much fluid was drained, etc. But this is what he told me. He also has a history of psoriasis, hypothyroidism, hyperlipidemia, and a remote history of polio, which is one for me and Vanessa to chat about later. But no residual deficits. His medications, he was on levothyroxine, just a topical steroid cream, atorvastatin. He had been prescribed furosemide and spironolactone, but he had stopped taking those medications himself because of his profuse diarrhea in the past week. His family history was notable for lupus in his mother, and his sister had scleroderma. In terms of the, I'm sorry, I'm really testing you here, but in the terms of the social history, he was white. He lived in the Midwest of the USA his whole life. He was a retired school teacher. Yeah, it's the coffee. That's right. He was independent. Pre-morbidly, he was independent to all his ADLs. He had a distant 5-pack year smoking history, no alcohol use. He was married and monogamous for the previous 50 years, and no known drug allergies.
Obviously, knowing his past medical history of cirrhosis is extremely important here. What I was going to say is, if I didn't know that, then I really am thinking about, okay, if everything is leading us towards there is ascites accumulating in the belly, I really think about the mechanisms of how ascites develops, whether it be through portal hypertension, from cirrhosis or cardiac portal hypertension, or inflammation of the peritoneum, because those all have vastly different differential diagnoses. In this case, knowing that he has a history of cirrhosis and ascites before, then obviously the most likely cause is that this is ascites due to his portal hypertension, which is from the liver cirrhosis.
And can I jump in and just say one thing? This is what he reported to me. I had no records at this stage, so I just want to reiterate that point.
Okay. Fair enough. Fair enough.
Vanessa, I think Jack's throwing us a softball. If you had to say,
fair enough.
If you had to say, what about this case makes you question the diagnosis of cirrhosis? If you had to apply that filter real quick, what would make you be like, huh, that's a little weird for cirrhosis?
You mean the filter of the different causes of ascites?
Yeah, no, that I mean, one, your approach to ascites is superb. I love how it was so simple. It's like, is it transitive portal hypertension or is it in the peritoneum?
Mhm.
I think that when people get the diagnosis of cirrhosis, we jump on that train, and I think we do so because we often do it right. But I think you got to be ready for when things don't add up. So is there anything about this case that makes you wonder, hey, you know what? I don't think that this adds up for cirrhosis, or that it makes me question the diagnosis a little bit at least.
Well, the thing that stands out from
Yeah.
historical history was a lack of alcohol use.
Uh-huh.
The other thing, of course, you get cirrhosis from other causes besides alcohol.
Yeah.
If he was coming in and telling me, I, for years and years and years, have been a very heavy drinker,
Yeah.
that would make a lot more sense and make me say, potentially that would fit with alcoholic cirrhosis. Just because you don't have a heavy drinking history doesn't mean that you don't have cirrhosis either, but there isn't a really heavy risk factor for that.
Yeah.
Other causes of cirrhosis can include, I think somebody mentioned what their BMI was going after NASH liver disease, which can progress to cirrhosis, which is also possible. But it really, again, there's other causes of cirrhosis, but not having a heavy alcohol history is one thing that makes me say, that's usually the type of cirrhosis that we see.
I could agree more with you. I think that you're teaching us something really important, which is that a disease has to be diagnosed in the face of risk factors for it. And I think in the lack of risk factors for cirrhosis here is one questionable thing. I think if we translate that 15 kilograms into pounds, that's almost 40 pounds.
Yeah.
So ask yourself, how many patients with cirrhosis have you seen lose 40 pounds in a 6-month period? Big red flag. Red flag. Possible for sure, but big red flag. Yeah. But I think this exercise illustrates how much harder it is to grasp onto pertinent negatives than pertinent positives. He doesn't have many things that you would expect somebody with this degree of decompensated cirrhosis to have. He's not confused. He's telling the story. To have somebody be this volume overloaded and not have even the slightest bit of hepatic encephalopathy is weird. But what's weirder is that he hasn't said the one word about him being jaundiced or have changes in his skin, which is another red flag. So for me, there's too much ascites happening out of proportion to the other things that tend to happen with cirrhosis. And there's too much weight loss, way too much weight loss. So, geez, if I'm hearing that word cirrhosis, I'm saying thank you, but I don't believe it. I really don't. And maybe I'm wrong, but I think we gotta think, I think we have to use the schema that you outlined and start in a different angle and hat tip Jack for his alley-oop, emphasizing that he had no records about this yet.
Yeah, my next question would be, they told you had cirrhosis, do you have the serum albumin,
Yeah, right.
the total protein?
Yeah.
Let's prove it.
Yeah, we're going to get there pretty shortly.
All righty, why don't you give us more data for the sake of time?
Yes, yeah. So let me just tell you on what I found on an examination. So his afebrile temperature was 36.5. Blood pressure was a little soft, 108/68, and his heart rate reflected that, was 97. His respiratory rate was 17. He was saturating 96% on room air. And his BMI, somebody I think had asked, his BMI was 22.4. This was after a bit of weight loss. So I think it's fair to assume that, his BMI was maybe 25, 26 pre-morbidly.
But not huge.
But not a big guy previously. Yeah. So generally he appeared cachectic. He had kind of mild frontotemporal wasting. His wedding ring was sliding off his finger. He didn't have his sclera were anecteric. His oral mucosa were dry. He didn't have any mouth, ulcerations or macroglossia. I couldn't visualize his JVP, and his heart, the rhythm was regular. He did have a 2 out of 6 systolic murmur at the right sternal border, and he had +2 pitting edema to his knees. His respiratory exam was benign. In terms of the GI exam, he didn't have any asterixis. He didn't have any spider nevi. The abdomen was kind of diffusely tender to examination, but no rigidity or guarding. I couldn't appreciate a fluid thrill on examination. And I did do a DRE, and there was no evidence of any fistulas or ulcerations or blood on the glove. His neuro exam was also normal. And then in terms of his skin, I mentioned there was no spider nevi, but he didn't have any other rashes or ecchymosis.
Yeah, that is really helpful. This is making me think back to when I was a third-year resident and I had a patient come in who had no suggestion at all in her chart of cirrhosis. And just with a really detailed history and physical exam, I walked into the room saying, this lady has cirrhosis. She had clear hepatic encephalopathy. She had esterexis. She had new ascites. She had all of those things. And you're really not giving me very much here that sounds like that, especially because, as you're pointing out, if it was cirrhosis so bad to cause this degree of ascites, not having a history of hepatic encephalopathy or anything else seems inconsistent. The 2+ putting edema to the knees is more than was suggested just from the history. It's funny how often patients will describe it as, very just, mild swelling in the ankles. And then you look and you say, well, no, you're actually very, very, it's quite edematous. And then the lack of jugular venous distension makes me suspect that it's something not related directly to the heart, that it's something more distal, which again would fit with the mass effect that we're seeing in the belly. Especially because I still have in the back of my head, do you truly have liver fibrosis, i.e. cirrhosis, that's causing your ascites? Is it possible that you could have something cardiac going on that's causing your portal hypertension and ascites? But the lack of jugular venous distension makes me think that's less likely. And you said diffusely tender to exam?
Just diffusely tender to exam, yeah.
Severely tender or just mildly?
Mildly tender, mildly
Okay.
tender, yeah,
Okay.
yeah.
I think you should write that in any jam response, Vanessa. That was amazing. That was so crystal clear. You've silenced me, which is a rare feat on VMR. Jack, why don't you tell us more?
Yeah, let me tell you his lab, shall I?
Yes.
So his white count was 20.9. The neutrophils were 17.9, and the lymphocytes were 1.19. Monocytes were 1.66. His platelets were 288, and his hemoglobin was 13.7. In terms of his BMP, his sodium was 133, his potassium was 3.3, chloride was 103, bicarb was 21, BUM was 18, and creatinine was 1.42. He had a normal glucose. His phosphorus was 1.1. And his magnesium was 2.2. I'll also give you a couple of other things. So his serum calcium was 7.5. That's not corrected. His serum protein was 3.6, and his serum albumin was 1.3. ALT, AST were 31, 37. And his bilirubin was low normal. Alk phos was 143. Just a couple of other things I'll give you when he came in. His lactate was 1.3, and his CRP was 38.
Any chances you have his UA? Just thinking about where the albumin is.
Yeah,
I do have his UA. I didn't give you that, Robbie, but yeah. His UA is pending actually right now.
Alrighty, you got it. Perfect.
So I think the thing that stands out the most here is his platelet count. Again, you wouldn't get this makes me think even less cirrhosis, because if you had such bad cirrhosis and portal hypertension that you would have ascites to this degree, you would also have splenomegaly and thrombocytopenia. His AST, ALT not being that elevated, you do get normalization eventually of your hepatocellular markers if you have long-standing cirrhosis, but so that doesn't really tell me things one way or the other, but it does make me think there's not active inflammation in the liver going on right now. Let's see. Obviously his albumin is really low, which exactly makes me wonder, is it being lost somewhere? Are we dealing with really bad malnutrition? Again, that makes me think that makes me wonder again, is it possible we're dealing with transudative ascites and peripheral edema? but again, not enough to make me say there isn't another process going on as well, because this could still be secondary to something else.
Yeah, I'm right there with you. I'm really surprised how inflamed he is. You know, as you pointed out, the CBC is not suggestive of portal hypertension at all. And the amount of neutrophils he has would caught me off guard. It's unusual for somebody to have a neutrophilic process be merged with a presentation that is 6 months in its evolution. That's weird. But I agree with you. I think you have to think about the albumin, not because it tends to be helpful in most cases, but it's certainly helpful when it's less than 2. And so while reduced synthesis of albumin can occur as a result of non-specific inflammation, when it's this low, it's usually a loss problem. And there are 3 places it tends to be lost. 1 is common and 2 are rare. And the common place is in the kidney in the form of nephrotic syndrome, which is very compatible with what we're seeing here. The other 2 places are much less common, and they're in the GI tract in the form of protein-losing enteropathy. And 1 is super, super rare. Sometimes you lose albumin into your interstitium from your vessels, from leaky vessels, which is only worth mentioning, really. And so I think that's why the UA is key here, because you will either go towards the GI tract reinforced by his diarrhea and call this protein-losing enteropathy, or you'll pivot towards the kidney and call this nephrotic syndrome. So I think analyzing the albumin in more detail will take you very, very far in this case. I think that's what I would do next. And we might be able to simplify this problem. We might be able to say, what is the cause of protein-losing enteropathy with inflammation in this person? Or what is the cause of nephrotic syndrome with inflammation in this 71-year-old man?
Can we back up? I forgot it. I had it in mind, but I forgot to ask Gunnar back in the history. Does he have edema anywhere else besides his lower extremities? Does he wake up with puffy eyes, anything like that?
He didn't endorse that, but that may have come to light later on.
Okay.
He's so good with these alley-oops. He's so good.
Yeah.
You know, I think that most people on VMR would just be like, can't tell you right now. But I think y'all are seeing how kind our dear friend Jack is. He just can't help it. Like he can't completely hold it back. He just can't do it. He's like, he doesn't have cirrhosis.
How about I just share quickly you know, because I think Rabbi, you've identified, and clearly me holding back the UA is pretty suggestive, but I want to show you just the CT. Do you mind if I share my screen just for a quick second here? I've just got some cross sections of the CT. Is that okay? That's okay.
Please.
Let's see. Where is it? Yeah. So are you guys seeing the CT here?
Yes.
Yeah, great. Okay. So this is the CT. And well, the first thing that I just want to point, that the radiologist did not comment on was some kind of a cirrhotic morphology of the liver. The liver looked normal. So what they really pointed out here was a couple of things. First of all, there is ascites, as you can see, around the liver, and then kind of in some of the more dependent spaces as the patient is lying down. And then really the other thing to notice here is really what was described as a pancolitis. So if you look at the wall of the colon there, you can really see how thick and inflamed that is. So that's what we saw. That's what we saw on the CT scan, and that of course had been done in the ED at the Mayo Clinic. It's very hard to get through our emergency department without a CT scan. So I've stopped sharing there, but that's just what the CT showed.
Vanessa, what do you think?
I'll be honest, I don't know that gives me a lot of information that I didn't already suspect. I think it confirms more. The lack of nodular liver morphology is, again, a point against cirrhosis, but I was already, doubting that. The pancolitis is interesting. That fits again with the weak history of diarrhea. But again, I don't know that it gives me much actual diagnostic information. And to be honest, I don't know that, again, pancolitis, the leukocytosis, all of those things, those might just be superimposed on another process too.
Yeah, no, I think that if you're trying to solve that albumin, you're like, well, maybe the pancolitis doesn't tell me any specific diagnoses, but maybe it pushes us towards calling the albumin as a protein losing enteropathy, which doesn't change the calculus of the colitis much, but at least it makes us start to move away from exonerating the kidney. But you need that UA to come back to be very more confident, right? And I think one helpful way of approaching colitis is the 4 I's, with infections being the most common, inflammatory diseases like IBD, and some other less ones being distant second. There are ischemic colitis can happen too, though this patient doesn't have any risk factors for ischemia. And then the final I is infiltration. And I think in a subacute progressive syndrome, inflammation by malignancy or malignancy mimickers like amyloid are certainly possible. So, I think what do we think about doing next? I think the UA is going to be really, really important. And Vanessa, as you alluded to early on, like what kind of evaluation of the GI tract do we need? We might be heading towards needing a colonoscopy for this person based on the colitis.
Yeah, very good. Well, how about I give you maybe I'll give you 2 pieces of information. So the first is, so the patient had a paracentesis when he came up to the floor. So the peritoneal serum albumin was 0.3, and you'll recall that the serum albumin was 1.3. And then the protein was the protein level was 0.5 in the peritoneum. And the TNCs were 216, was a 71% neutrophilic predominance. So the serum albumin acidic gradient was 1.0, and then the protein level was 0.5 in the abdomen. And let me just, we won't bury the lead any longer. The UA showed a lot of protein. I'll give you another couple of little pieces on the UA that were kind of raised an eyebrow for us. First of all, there was a bit of glycosuria, and the glucose in the UA was high, was 75. The pH was 5.7 as well, and just those couple of things kind of made us go, huh, that's interesting. And then in the meantime, in the background, we were doing a 24-hour protein, and I'll give you the number. It was 6.6 grams of protein as well there.
Whoa, that's a lot. Okay, so I think we know where the albumin is going. So he definitely has nephrotic syndrome then. The acidic labs are really, really helpful because, again, this definitely makes me think much more of a transudative process than exudative, especially with the protein being that low. And I'm really worried about his kidneys now. I especially with that glucose urea, I'm guessing that's in the setting of semi-normal serum glucose.
Yeah, normal serum glucose.
Okay, so higher than it really should be.
Not an SGLT2.
Okay. Yeah, I'm really worried about his kidneys now.
No, can you imagine that, Vanessa? Do you imagine like this case from the beginning? Like if you just go back and rewind the clock 40 minutes, probably less than 40 minutes because we were battling so much initially, which means we were having a great time. That we would end up calling this nephrotic syndrome. It's really, really intriguing, the journey that we're on here. And I think that we should talk for a second about nephrotic syndrome, which is always confusing because immediately when we start talking about nephrotic syndrome, an alphabet soup of histopathological entities starts to emerge. Like, is this amyloid, or is this membranous nephropathy, or focal segmental glomerulosclerosis, or is this membranous nephropathy, minimal change disease, like all those things. And what you can take away from how hard that conversation is the following fact. Most people with nephrotic syndrome have an isolated renal disease, and that's why you need to biopsy them. Very few, less than 20% of patients with nephrotic syndrome have a systemic disease associated with their nephrotic syndrome. And so we know that we're dealing with something really unusual here. And it's helpful to know a good first pass workup for nephrotic syndrome that we do systemically, and that's to look for the trifecta of infections, the H's, HIV, which can definitely do a colitis, HBV, and HCV. And then to think, are there any autoimmune diseases that do it? And the answer is yes, of course, but the most common one is not at play here, and that's lupus. There are many other ones, including IgG4 disease, sarcoidosis, mixed connective tissue disease, and others, but those are unlikely in this patient because all of them except lupus are pretty rare. The cancer category deserves a lot of impetus here, in large part because the patient is losing so much weight. And in the context of membranous nephropathy, GI malignancy is actually the most common cause of a secondary cause of membranous nephropathy. But I think the key thing to realize in this case is not only do we have a systemic signature with the neutrophilia and the pancreatitis, is we also have a little bit more renal localization, and that this patient is having euglycemic glucosuria, which tells us that we're dealing with not just a glomerular disease, but also a proximal tubular disease process. That has an extensive DDX, but the main categories that come into play are paraprotein diseases. So if you're thinking of what could be at play, the associated likely RTA type 2 or proximal tubular disease reinforces the concern about amyloidosis in this case, but also is actually a feature of collapsing glomerulopathy from HIV. So a really aggressive version of FSGS. So what does this patient need? I think you need to get all that serological workup that we just talked about. And a lot of these patients get a kidney biopsy to understand the underlying histological pattern for their disease process. Really, really tricky case. I'm stunned that we're talking about nephrotic syndrome in a case that
It's been a journey. So that's exactly, the workup that we did next. So we got, ANA, anti double-strand DNA, C3, C4, we got a chest X, we got a HIV, we got a hepatitis B, C serologies. All of them were normal or negative. We got a serum anti-PLA2R, which of course takes a couple of days to come back. And in the meantime, then we actually we did an SPEP, and that was the one that was. So what we saw in the SPEP was a small IgG kappa monoclonal protein. So our alarm bells were ringing at this stage, for the reason that we've all discussed. We did a couple of things. Nephrology were engaged, and we were kind of like, what are we gonna do with it? We're gonna biopsy the kidney. In the meantime, so we did a couple of things. It was a GI service that he was admitted on because he had cirrhosis, right? So we actually ended up doing an EGD and flexible sigmoidoscopy. And in particular, we were looking for any evidence of amyloid in the GI tract at that stage, and we didn't see any. We just saw reactive colonic mucosa, and then we also did a fat pad biopsy, and that was negative as well. So that was kind of our workup, and of course then I suppose that's all leading us up to what I think you had both mentioned as as a test you might like to get. Being a renal biopsy. So that test kind of sealed the underlying diagnosis ultimately.
What do you think?
I'm really wondering about membranous nephropathy for him. It's the most common cause of nephrotic syndrome in white. The white population, especially with these other things coming back negative. I know we're waiting for the PLA2 receptor antibodies. It is associated with some of the things that we've discussed already, but that's really what I'm wondering most about right now.
Yeah, 100%. I think that it has to be up there. How do you merge the SPEP findings? What does that do for you?
Part of what I wonder with that too is, I also always think that some of this could be reactive as well, especially with these other things that we're seeing on with inflammation. He doesn't really have an anemia or osteolytic bone lesions or anything else like that going on.
I know it's tricky. I think that if you look at the SPEP, you're like, wait, hold on. What could that be? It could be that he has an MGUS, an unrelated monoclonal gammopathy of uncertain significance, or it could reinforce your notion that he has a paraprotein-related kidney disease.
Right.
Our hypothesis of this being AL amyloid is significantly weakened by the fact that this is a kappa monoclonal protein. The vast majority of AL is actually lambda. But you could have amyloidosis's cousin, light chain deposition disease, which causes the exact same issue that amyloid does. So I don't know. I don't think you can be confident before the renal biopsy. By the way, if you could be confident before the renal biopsy, you probably shouldn't do the renal biopsy. So I think for me, it's a toss up between the most common membranous. The holes in membranous are that for it to be so systemic, you need to find another underlying reason, like a cancer. The supporting feature of amyloidosis is this is a systemic syndrome that involves the GI tract and involves the proximal tubule, which is a powerful clue for amyloid. The weakness of the amyloid hypothesis is that this is a kappa protein, but that weakness can be reinforced and plugged in by invoking its cousin, light chain deposition disease, which is a very similar but slightly nastier disease. Cue the reveal.
Yeah, so this is just an amazing discussion, and because obviously we were not blinded at the time on the ward, but we were reading about it, but these were the thoughts you guys are having now, blinded, were the exact thoughts we were having, doing a lot of research. So I was convinced this was going to be a monoclonal gammopathy of renal significance, right? When we were waiting for the biopsy, but it turned out we got the biopsy results, and it was Pla2R. And then the serum antibodies came back at 25, which were elevated. So this was like a Pla2R deposition, causing a membranous nephropathy and a nephrotic syndrome. So that's the reveal. I'll give you a couple of other points. So actually we did run a stool panel, and he came back for C. diff as well. So he just had C. diff on top of everything else that was going on. And I think, the thing to remember in nephrotic syndrome is that folks get an immune paresis, where they lose immunoglobulin. He'd been in hospital. He hadn't had any antibiotics, but he was kind of like a sitting duck for a superimposed infection, right? So he just had C. diff, and then he had this 6-month, progressive nephrotic syndrome, I guess. And then the other curious points, and Rabbi, you mentioned it, the thing that we were still wondering about a lot was okay, well, why did he get this proximal tubulopathy, right?
Yeah.
Where did that come from in the absence of an amyloid or a light chain deposition process? So what we were reading about it, and it seems that in the setting of severe vitamin D deficiency, you can get a proximal tubulopathy. And so obviously we were doing our workup for, our kind of associated kind of sequelae of nephrotic syndrome, and he had a severe vitamin D deficiency.
Oh, wow.
Yeah. So that was one of my teaching points that I wanted to raise about acquired Fanconi syndrome. So, in terms of the causes, I just have kind of written down a little list, multiple. So myeloma is the one that we most frequently encounter, right? But nephrotic syndrome and vitamin D deficiency can also cause it, and then some other medicines like tenofovir and ifosfamide are the common causes of acquired Fanconi syndrome, as well as some heavy metal poisoning like lead and mercury in particular. So yeah, that was a real kind of I think interesting quirk that was a kind of a learning point for us on this case.
I did not know that vitamin D deficiency could cause proximal tubule disease like that. That's really good to know. Wow.
Yeah.
How low is his vitamin D?
His vitamin D was 9.
Wow.
Yeah.
Wow.
Yeah.
That's incredible. Yeah. I'm just one. I think Vanessa, if you listen to your case discussion closely, you might have an existential crisis about not choosing nephrology, which is okay. Which is okay. I think it just terrifies me as to how good an IU doctor you must be if you have chosen to do something else instead of nephrology. It really does. It's kind of scary. But
IU doctors are internists first.
Yeah, 100%. So true. I think what you taught us is just how powerful the base rate of the disease is. At the end of the day, even when a case is throwing distractors at you left, right, and center, how the common thing just is always the dominant variable. So even as we accumulated clues to say, hey, this is weird because of this and this and this and this, we were able to patch those holes in ways that are also common, like saying, hey, you know what, vitamin D deficiency is very common. It caused the RTA, and wait, hold on, immunoparesis causes infections. And so suddenly the colitis vanishes away and is explained by the nephrotic syndrome, and the vitamin D deficiency explains away the other thing, and becomes a simple case of abrupt onset nephrotic syndrome in an older white man, which is really, really intriguing, and a wonderful journey to have gone on with you.
I think these things are always hard because we look for unifying diagnoses that combine all of these things, because those are often so satisfying. But I've also found, I had a case just a few weeks ago where I had to really sit and think and chart out to myself, okay, the domino effect that can happen. And I actually find that to oftentimes be just as satisfying to explain to myself, what are the consequences of diseases and how does that lead to other things that all present at once? It's not necessarily what we think of when we're in training, when we look for one thing that unites everything, but I also think it can be just as interesting.
I think this is, and this is, you know, a point I've made a couple of slides on, is like, I think this is the classic Occam's razor, Hickham's dictum, like the patient gets as many diseases as he damn well pleases, right? So we diagnosed this guy with C. diff colitis with, you know, a secondary to anti-platoire, hyperlipidemia from the nephrotic syndrome, a vitamin D deficiency from the nephrotic syndrome, an acquired Fanconi syndrome, an MGUS as well. That murmur turned out to be a bicuspid aortic valve, and of course he also had a rip-roaring malnutrition. So, so this guy just had a lot. You know what? I just want to commend both of you. Wow, like from it was just like, I was like, holy crap, like they're already like 10 steps ahead. And when I was like presenting like the second aliquot, it was just, my mind is blown just watching you guys.
Oh, my mind is blown just like seeing your energy that you all have, and the kindness and the clinical brilliance and the passion for learning and for medicine, and the curiosity that you have to dissect this case, and the teaching that you're imparting on it. It's unreal. It's unreal. And it's certainly a fraction of the hard work that you're doing and the people that you are, but also hard not to see it in the mirror image of the great program that you come from.
You know, one thing I will say is we talk a lot about this here as chief residents. Whenever we get to be on service working with residents or staffing in clinic, we're always so excited to do medicine together. We love to go to the Friday case conferences when our residents stand up and show interesting cases. There are some fascinating things going on every time we go back to our workroom and say, did you know that? I didn't know that. Why didn't I learn that yet?
Incredible. Well, it looks like there's a lot of questions coming in. I'd love to ask you one question that I was going to ask you in the middle of the conversation, but I got too distracted by the case, which is, do you know the history and the story of why your attendings are referred to as consultants? What is that? What is there a narrative behind that?
I don't know when it started. The idea is basically that the words you use really affect how you think about things, which I totally buy into that. My father always told me it's not pimping, it's positive learning opportunities. So I buy into that argument. And I think the reason we call our attendings consultants is the idea is, as the residents, you are the doctors, you are the ones who take responsibility and ownership for the patients. And so the consultants, just like a consulting team, are there if you have questions and to help you out. But it's really trying to give more autonomy to the residents. I don't know the actual history. I think it's always, that's what we've always called them here, but I don't know that for sure.
Yeah, no, that's what we've always heard, that it's been very much like, you know, they're the consultant, as in the senior resident at Mayo leads the team, and then the consultant is there as like a little mini curbside / consult service. I will say, you know, in Ireland we call attendings consultants. And the Mayo brothers were English. They also call the attendings consultants in English. So maybe it's just a hang up from that, you know, that system either. I'm not sure.
I didn't know that you called them consultants.
We do.
In
Yeah,
Ireland.
we do.
Oh,
So
cool.
Mayo feels very at home for me. Yeah.
Awesome. Aya is telling us that that's the same where she went to medical school.
Interesting. Interesting.
That's so cool.
Our chief group has started a list of Jackisms this year of all the Irish things he says.
Amazing. Well, it looks like Marcella has a question for you all. Marcella, can you unmute and share it out loud if you can?
Yeah, sure. Thank you, Javi. So I was wondering, what do residents usually do for fun in Rochester?
In Rochester?
Yeah.
Well, so like I said, I'm from Washington State, so I really enjoy doing outdoor activities. I've actually picked up a lot of new hobbies in Rochester. When I first moved here, I was a little bit nervous because I'm so used to mountains. But I've actually been able to start cycling here. Right after match day, I decided, oh, the area is really good for cycling. So I bought myself a road bike, which is sitting in my living room now, so it doesn't get too cold. The Boundary Waters up in northern Minnesota is such a unique area. There's nowhere like it that I know of anywhere in the country. So I've gone up to the Boundary Waters many times to go portaging. There's actually, I didn't realize this, there's actually rock climbing in the area within, an hour drive. There's several crags that you can go rock climbing at. Let's see, cross-country skiing. Oh, I love cross-country skiing. I have my skate skis also sitting in the corner waiting. I was at one of our local parks last night and I saw that they have started grooming the trails. There wasn't that much snow because it started melting, but I'm really excited to go more cross-country skiing. I have started a list of residents I'm going to take skiing. And
myself and Vanessa, I'm gonna trade her my limited knowledge of downhill skiing, and she's gonna teach me how to cross country ski this winter. That's our plan.
Our goal is to get the chief group out to the ski slopes. One of the chiefs has informed us that she will be sitting inside drinking hot chocolate, so that's okay.
It's very outdoors place during the summer. Marcella, I play a lot of golf. There's a great golf here, very cheap and accessible. And then I play a lot of tennis as well. Enjoy hiking as well. And Minneapolis, is like an hour away as well. So, there's a lot to do and see up there as well.
Yeah, I think that we really enjoy outdoor stuff, but a lot of our residents really do not. So you don't have to be an outdoorsy person at all. One of the nice things about Rochester is that the city is actually investing a lot into the downtown, the restaurants. We have some really good restaurants. Even in the few years that we've been here, we've seen some really great restaurants open up. There's a lot of cultural activities, especially up in the Twin Cities, which are only an hour drive away. So it's actually a very nice combination of being in a town that is very livable, very accessible, short drives to work, which is honestly what you care about when you're working long hours. But then when you have a weekend free or on an easier rotation, being able to drive to go have access to amazing concerts and cultural events, amazing bookstores, really good food is a really nice combination.
Can you tell that we do recruitment for the residency?
Yes, and very well. That sounds amazing. Thank you so much.
There's a lot of good breweries in town too. I will say one of our former residents actually owns one of the most popular breweries in town. So we do a lot of events there too.
Nice. Amazing. Well, it looks like it's hopping over residency a little bit. It looks like Andrew has a question for you about fellowship. Andrew, can you unmute real quick? I don't know if Andrew's still here. You might have had to bounce.
Oh, Jack, what factored? I can see it in chat. What factored?
Oh, okay, go for it. Yeah.
Yeah, I can see that. I can see. So what factored into your staying at Mayo for fellowship? So I mean, gosh, where to start? Like I love Mayo Clinic. Like the culture in the hospital is just so kind. People are so humble here. And so, like, I work every day with really the world experts, just the most talented people in medicine, some of the most talented people, and you wouldn't know it, they're so kind and willing to teach you. And the hospital itself is just like a Disneyland of medicine. We have any resource a patient needs, they can essentially get. And it really makes you feel like you're caring, you're able to provide the best care possible for the patient. And that's a really it's so satisfying to be able to do that, and then just the teamwork, there's just a teamwork, that's kind of like the heart of Mayo Clinic, I think, is teamwork and collegiality amongst the specialists. So it just makes it just a really, really special place to go to work every day.
The ID division here is absolutely amazing. Again, that's what we're both interested in. So that is what was foremost in our minds. But I had a case a few weeks ago when I was the consultant on the team. As chief residents, we staff some of the inpatient services with the residents. And there was one day where I frankly made a bad call with regards to an infection. I said, I think this is just osteomyelitis. Let's not start antibiotics because I want to increase our yield when we do intraoperative cultures. And overnight, the patient went septic. And I came in the next day and I felt really bad. And the patient ended up being fine, but I felt bad. He got pretty sick. And I was frustrated with myself because I thought, what did I not see? What did I miss? And, it's when you make the wrong call in medicine, it's really hard, I think, to be honest with yourself and say, that was not my best. I could have done better. What can I learn from this? And I had a moment where I said, I just don't want to think about it. And I decided, you know what? No, I trust the consultants here. I trust my mentors. And so I reached out to one of the infectious diseases consultants here who was following the case. And I said to him, I made the wrong call. Can you come by the workroom and teach us and show us what I missed? And he came to the workroom, he sat down with the interns and with me and drew out really his approach to how he would have thought about things and walked through a timeline with us and helped me think, okay, at this point with this information, what should you do? At this point with this information, what should you do? And it's a really wonderful thing when you can admit to people, your superiors, I made a mistake, I didn't see something. I think a patient was harmed because of it. Can you help teach me what I didn't know and what I didn't see?
That is really, really powerful. I really, really appreciate that. Very important messages there. I say messages because I think the one that you're emphasizing is the safety of the learning climate, but also the camaraderie and also the desire to learn and grow, to overcome those acutely emotional barriers. I think we all feel very, very powerful.
One thing
I was just going to say, one thing I would encourage
all the medical students on to think about is I have found so much value in being at a program where I could look at my co-residents around me and my consultants and really be inspired by them, both with how much ownership they take of their patients, how much time they spend with their patients, their academic curiosity. But again, more specific to this, being in an environment where people are willing to sit down and think, did I do wrong? What could I do better next time? That is a really, really valuable thing that I've been incredibly grateful for through my training.
Wonderful. Wonderful. Thank you so much. I'm trying to go through the chat to make sure we have everybody's questions asked, but I know we're actually over time. So you guys, maybe we can use ask you for a couple minutes more of your time, because I know Deborah and Andrea have questions. So Deborah, do you want to ask your question, and then Andrea, and then we'll call it a day?
Yeah, thank you for the case. It was really good. I think my question was, what do you think that is unique about the program? I think Vanessa was talking a lot. Maybe Jack can tell us what is unique for him.
Yeah, and I think I kind of hit on it in my last answer. In terms of what's unique for me, is really the culture of collegiality. Despite the fact that you really truly are working with incredibly talented people, it's a very, very kind culture, people. There is no, when you ring up a consult service, it's never this is a silly consult. It's how can I help? How can we help the patient? The motto of the Mayo Clinic is the needs of the patient come first, and like every single person in the hospital, from the CEO to the folks who are working in the facility services, allied healthcare staff, every single person I truly believe lives that value. And it just makes it a wonderful place to go in and work every day.
Thank you.
It's a real, we use the term servant leadership sometimes, and I think that's exemplified at Mayo Clinic.
Really do run the recruitment. Wow, I feel like I want to go do recruitment all over again at Mayo Clinic. Andrea.
I am actually in Rochester right now. I'm doing my medicine next week, and Jack, you're gonna be my consultant on next week. On the week of
I will tell you, as a consultant, he walks really fast down the hall. So wear your running shoes.
I am. Oh, they told me to wear a complete suit. I was going to ask in Peru, like I go to medical school in Peru, and every time we have a very rare case. I remember one my attendant said, "Oh, that's a case for Mayo Clinic. Like that's a case. Think about bread and butter, not like zebras that you would get in Mayo Clinic." So I think you have the idea that you are going to be very rare cases in Mayo Clinic, very complicated cases, and sometimes you are afraid to don't see the bread and butter. I don't know if you have the experience with that.
Yeah, that was one thing that I remember thinking about too when I was applying for residency. And frankly, that has not been my experience at all. I feel extremely confident with bread and butter cases. I mean, it's called bread and butter for a reason. We do have people who come from far away. And those are often the kinds of patients that you'll see in your subspecialty clinics as an outpatient. So you do get to have exposure to those complicated cases where you're working directly with world experts and learning from them. But even in those outpatient clinics, most of what you see is still much more common. And, we have people who used to be community doctors as well. And so they are also very helpful because they can say, yes, there is a little bit of a selection bias of people who travel, but this is still what you see in the community. And this is still reflected here. In our distribution of cases. And then on the inpatient setting, it's very much bread and butter cases. I do think it's a nice balance of being able to get very, very comfortable with these simple cases, but also always having to think, as a referral center, you need to keep these other more rare cases in mind as well. When you think about it in a differential, we need to think, if ever we rule everything out, when do we start thinking about these things? And again, by having world experts in different specialties, it also allows us to think and talk about these things, even though they usually end up being the more common diagnoses anyway. So I feel extremely confident with bread and butter cases. I have no concerns about that whatsoever.
Yeah, same. Yeah, the St. Mary's Hospital where we do our inpatient medicine, it's like everyone in Rochester and like the surrounding counties, like who get sick comes here. So it's just like normal, like any other hospital you would be going to.
I could totally understand why people would wonder if you can tackle bread and butter medicine when you can unlock a case of membranous nephropathy in front of a live audience. I think it's a very fair question. I know my dear friend Luis, with sporting his very proud Brazilian shirt. I love it. I love it. Yes. You had a question for the team. I know that they answered a little bit about what they like about the program, but feel free to ask.
Yeah, I mean, hi, I'm Luis. I'm from Brazil, as you can see. I'm an applicant this year, but yeah, my question was, what do you guys love the most about Mayo? But I think you've already answered that, and thank you for sharing your perspective on this.
Amazing. Well, we really appreciate all your time. Appreciate you taking the time to put the case together, Jack and Vanessa, to be vulnerable and to tell us about your vulnerability and discuss a case online in front of these people. And I don't know if they told you this goes on YouTube for anybody to watch it, but I don't think I think that you should beam at pride that exists now. And thank you to all the CP Solvers team members for organizing this, and appreciate you hanging out for a little bit of extra time.
Thank you, guys. This was fun.
Thanks, everyone. Thanks, Rafa. Thanks to the whole team and to Ravi too. That was amazing.
Bye now.
Bye.